We have a lot of people dialed in from all over the country and actually some from around the world, and so we're very excited to have you all here. I was really excited also to have some of my dear friends and colleagues agree to present their work on ultrasound and the principles of ultrasound today. So just to give you a little bit of history, as you all know, I think probably we can thank the gynecologists and obstetricians for really using ultrasound to the max in their practices. And then over the 90s and 2000s, there was an introduction of ultrasound into trauma and into some of general surgery, especially in Europe. With regards to liver ultrasound, certainly the Europeans have been far ahead of us, and so the person that has taken us, I believe, on the HPV side to the next level has been Dr. Ellen Hagopian, who really has taken the training paradigm to the next level. I was really honored that she agreed to give a talk today on some of the backgrounds of ultrasound, and she's going to be trying to condense a lot of information into a relatively brief talk. Next, we're going to hear from Eddie Cho, who's one of my partners who actually finished an HPV fellowship and is in practice with me here in Dallas. And he learned, I think, through education with Dr. Hagopian and then spending time with us, with our practice, to use ultrasound on pretty much every case. And our principles are to have the ultrasound pulled for every case that we do. And I asked Eddie to talk about pancreatic ultrasound because actually this is a topic that I think is highly underutilized and highly underrepresented. So very grateful to Eddie, who's very dear to me, for agreeing to present on pancreatic ultrasound. Next, Erin, who's a dear friend and is a sort of somebody who has made ultrasound of liver just part of daily practice. I've asked Erin Berber to go over the principles of liver ultrasound and how this may be useful for us. And then last but certainly not least is somebody who really is so far ahead of the curve that David Ionetti, as a dear friend and colleague, is not just thinking about what's happening now, but he's thinking about what's happening 10 years from now, and it's been such an inspirational force in bringing ultrasound into mainstream HPV work, not only in clinical practice, but also from a research standpoint. Finally, what I'm going to do is I've put together a few cases that I thought would be good for us to talk about, and I'll be asking the faculty to jump in and give me some ideas around just the clinical dilemmas that I'm presenting, but also around how ultrasound can be useful in each of these cases. And then we'll sort of have a discussion with using these as a taking off point. So without much ado, I would like to introduce Ellen Hagopian, who is in New Jersey, who's a dear friend and colleague and really has made me so much better at ultrasound over the years. Ellen is going to talk to us about the background and principles of ultrasound. Thanks again, Ellen, for agreeing to do this.
Inviting me to this very esteemed panel. You know, you call me a good friend, and you're a good friend to me, as is David and Aaron and, of course, Eddie. So I'm really happy to participate here. And Dr. J. Raja has asked me to speak about background and principles of ultrasound. So I have no disclosures. So we really have multiple objectives for this first lecture. And that is to really come to an appreciation for how we use ultrasound during liver and pancreatic surgery. I really want you to have also just be able to briefly describe some of the physics, because you'll learn that you really need to know that in order to utilize ultrasound properly. Look at the various imaging modes and also the basic instrumentation, which is really important in utilizing ultrasound. The controls, the adjustments, And then, of course, lastly, to describe the echo characteristics of a tumor. So really the uses of ultrasound in liver and pancreatic surgery, I like to think about it in three different ways. Define what we do know, to find out what we don't know, and then to guide our procedures. And that's really what it is in a nutshell. So in liver ultrasound, we can use ultrasound to evaluate those liver lesions that we know about. We can find new lesions and, of course, guide some of our hepatic procedures. And so how can we do this? We can do this by having our CAT scans right in front of us in the operating room, and we can identify where those lesions are in the liver. We can identify areas of vascular involvement, and of course, during any kind of laparoscopic procedure, we can even stage the disease. We can identify lesions that we don't know. And of course, ultrasound, intraoperative ultrasound, has a very high sensitivity and specificity. But of course, it is very user dependent, which is why all of you are here and why a lot of you take the training courses. So here are a couple of examples. This image that is on your left, you see that this is a tumor that is in the liver, and we identified that tumor. It was a metastatic melanoma tumor under ultrasound laparoscopic. But we thought that this was really the only lesion that we were dealing with. But as we looked closer, we could see that there were actually multiple lesions in addition to this one larger lesion. So in this fashion, it really changed our management for this particular patient. Again, guidance of procedures. Now, guidance of procedures in liver ultrasound can be thought of as placing a needle into a tumor, such as for ablation that Dr. Nitty is going to talk about later. We can use it for biopsy. We can utilize it to localize the lesion and determine resectability, the extent of the operation, and plan the operation. What's really important in laparoscopic and minimally invasive procedures is that real-time ultrasound guidance of resection, and surgeons who do minimally invasive hepatic procedures will tell you that they constantly use ultrasound, and that's what we need to do during these procedures, because you don't necessarily have our hand in there to really guide the operation. And then lastly, confirmation of the completeness of resection by doing an ultrasound at the end of the procedure. So in the pancreas, much of the same. We identify where the lesion is, and we can identify the extent of the tumor. We can determine with very high sensitivity vascular invasion. Ultrasound is particularly useful, for example, during a limited resection of the pancreas and nucleation of pancreatic islet cell tumors, drainage of cysts, and of course identification of the location of the pancreatic duct. Here's an example of vascular involvement that you see. Here is a tumor that's in the head of the pancreas that's really right next to the SMV. And it looks like there's invasion here, but we see that when we use duplex that this excludes vascular invasion. This is another example of actually a neuroendocrine tumor right here, this hypoechoic lesion. This is the SMV splenic vein confluence, and this particular patient had no imaging evidence of this small pancreatic tumor except for a dilated duct. So what is medical ultrasound? Well, ultrasound is really just sound above what we can hear. That's what ultrasound is. And so typically the frequencies that are used in medical ultrasound range from anywhere between 2 megahertz, sometimes as low as 1, to as high as 20 megahertz. There are some clinical applications that we use in ultrasound that are as high as 55 megahertz, but in general, for our purposes, we will go to about 20 megahertz. So what happens to sound? So this is really important. You know, when sound is emitted from something, several things can happen. Either sound can be absorbed from the tissues around where the target is. The sound can move forward and then it can be reflected back, or it can actually go through a target and it can be refracted or scattered. Now, when sound is emitted from the ultrasound probe and is reflected back, that's what the ultrasound probe will hear. And the absorption, the scattering, and the refraction of the sound is what we call as attenuation, and that's the loss of the sound energy. So what's also important to understand in ultrasound physics is the piezoelectric effect. And the piezoelectric effect is essentially the conversion between electrical and sound energy. There are, within the ultrasound probe, there are piezoelectric crystals which have the property of converting electrical to sound energy and sound energy back to electrical energy. So what happens is that the ultrasound system will create an electrical energy, and it will apply that energy to the crystals, which will then vibrate and create sound. And so that then creates the ultrasound, which then moves forward to whatever target we're looking at, and then the returning sound waves come back to the probe. And again, that energy is converted back into an electrical energy and then creates a picture onto our monitor screen. So in medical ultrasound, especially intraoperative ultrasound, there's really only a couple of modes that you need to be aware of and you really need to use. And that's really B mode and then Duplex Doppler. So B mode is that very common ultrasound image that we are used to. It's called B mode for brightness. In more modern terminology, we call it two-dimensional mode or 2D mode. So when looking at your ultrasound system, you may see B or you may see 2D that may indicate B mode. Duplex Doppler, we all know what Doppler is. We use it every day in vascular ultrasound. So Duplex Doppler is just that combination of B mode plus Doppler. So in this picture, in this image of the liver, this cursor, if you see here, is on a hepatic vein. And at the bottom here, we see the waveform for that hepatic vein. So Duplex Doppler will detect flow within a structure, vasculature. And Doppler mode can be either spectral Doppler or color Doppler. Spectral Doppler being much of the same of what we just looked at, placing a cursor over what's depicted here is a portal vein and looking at the waveform below, or color Doppler, where color Doppler we can determine the speed and direction by turning on color, and we can see the direction of flow. In general, the flow that is toward the probe is red and flow away from the probe is blue. However, that can be changed to your preference. So that you can change on your ultrasound system. But in general, that is what is programmed. So the basic instrumentation for ultrasound, obviously we have our display monitor, we have the keyboard that we're going to talk about in depth, we have the central processing unit, which is right here, and then of course we have the transducer or probe. two interchangeable terms. So in the operating room, we use various types of ultrasound probes. These are the most common. For intraoperative ultrasound, we have the T side viewing probe, a T probe, or a T probe, which, as you notice, the ultrasound crystals are perpendicular to the shaft of the ultrasound cord, and that's why it's called a T. Or we have an I viewing, which is parallel. The ultrasound crystals are parallel to the shaft of the ultrasound cord. In laparoscopic ultrasound, we have flexible probes and we have rigid probes. In most cases, we use flexible probes for laparoscopic procedures. So let's talk a little bit about resolution. So resolution of the image in ultrasound is obviously one of the most important things, is optimizing your image in addition to being able to interpret your image. So let's talk a moment about low frequency versus high frequency. So high frequency probes have better image resolution, as opposed to low frequency probes have less image resolution. The reason for this is that in low frequency probes, which are usually 3 to 5 megahertz or so, low frequency probes have a much longer wavelength. And because they have a longer wavelength, they have less image resolution. However, they have, because the sound attenuates less, they have deeper penetration. So this is in opposition to high frequency probes, 11, 12, up to 15 we use in the operating room. High frequency probes, short wavelengths, have superficial penetration or less penetration, but much better image resolution. And we will look at some examples of that in a little bit. So just to reiterate, resolution: high resolution, high frequency; low resolution, low frequency. The depth of penetration is superficial in high frequency and deep in low frequency. So let's talk about knobology. So this is probably one of the most intimidating parts of doing ultrasound is the keyboard. I've got all these keys in front of me, and what do I do with all of them? And to be honest with you, there are really only a few, more than a few, but just not many controls that you really need to master in order to optimize your image. So this is all really about optimization of your image. So let's start with frequency. We just spoke about frequency. We talked about frequency of the probes. Now, probes are typically multi-frequency. So you may get a probe in the OR that can range anywhere from 5 to 15 megahertz, or it may range from 7.5 to 15 megahertz. When you adjust your frequency on your ultrasound system, you're adjusting the frequency that probe is programmed to be. So most probes that we use are multi-frequency, and when you're in the operating room, you can adjust that frequency. So when we talk about frequency, we talk about resolution, which is just what I was speaking about. So if you have one word for frequency, think about resolution of the image. So this is an example of the same exact image, but with two different frequencies. So the image here on your left is at 5 megahertz, as opposed to on your right is 13 megahertz. So what I want you to do is I want you to look at right here. You've got some sort of a structure right here. And at 5 megahertz, which doesn't have great resolution but has better penetration, we think, well, is there something there? Well, then we change the frequency, and then we see right here, there's actually a vessel there at 13 megahertz. But then look at the depth of this image. You'll see at 5 megahertz, you actually can make some structures out, but at 13 megahertz, you can appreciate that the penetration is lost. So increasing that frequency improves resolution, but it's at the expense of the depth of penetration. So gain, if you had one word to think about with gain, it's really volume. It's like turning up your radio. It's volume amplification, and it's volume amplification of the returning echoes. So remember, we talked about what's emitted from the ultrasound probe is actually power, but most of the probe's time it's spent not emitting ultrasound waves, but it's spent listening, and that's what gain is. Okay, so gain is volume amplification of the sound of the returning echoes, and these are three different images. This one right here is at a low gain. In the center is correct, and that on your right is too high of a gain. And you see that as you increase the gain, you increase the brightness, you increase the noise. So think of it almost as noise too. On some ultrasound systems, the gain is actually indicated by a B because it stands for brightness, which can be confusing at times because we do have B mode or brightness mode ultrasound. So time gain compensation is very similar to gain, except for time gain compensation applies a different amount of gain at various levels. We call it TGC, and it almost always these knobs you will see almost always in the upper right hand corner of your ultrasound system. So this is an example of just uniform gain or TGC throughout the entire image, and you see the amount of gain at the top is pretty much the same amount of gain at the bottom. But then if we move the gain at the top all the way down, low gain at the top to high gain at the bottom, we see at the very top is very dark, and at the bottom it becomes very bright. So this helps us adjust we can adjust the gain at varying depths, really based upon the absorption or attenuation of the ultrasound echoes. So depth is indicated by various configurations on various systems, but think about depth as really distance. Depth equals distance, and by adjusting the depth, this is increased depth, and this image on the right is a decreased depth. And as you decrease the depth, you can really focus in on something, and you can actually increase your resolution by decreasing the depth in some cases. So this is also a very useful tool and a useful adjustment to use. Focus is really the point of interest on your image, and the focus is usually indicated by maybe a couple of arrows, and typically the focal point is going to be right in the center, but we can adjust our focus at various levels so we can try to optimize our image. You see at the left, we want to see something that's a little bit more superficial, and as we change our focus, we can see things in better resolution. So freeze and measurements. A basic thing that you need to know how to do is to freeze. Almost always the freeze button is a snowflake, and you need to know how to measure, save and print. this becomes very important, freezing and measuring when you start to do ablations. The knobs can be very, very, very intimidating. So you have to get to know your machine, and you have to really mark your machine. I recommend to you. So here we've marked Doppler, color, brightness, depth. And this is helpful not only for you. Once you get to know your system, you'll know what to adjust. But if you're scrubbed and you want somebody to help you, you can ask them to make those adjustments for you. Or you can put on an extra glove, or you can cover your system, all kinds of various things that you can do when you're in the OR. So really just to wrap up, you need to understand and be able to talk the talk, right? So we need to know what each one of these things indicates. So something that's black, we referred that as anechoic. The reason why is because it lacks any sort of returning echo waves, and so we call it anechoic. The most common thing that we see that's anechoic is something that's fluid filled. So completely water filled or clear fluid filled something, it's going to be anechoic. Hypoechoic refers to a lesion or some sort of pathology that is less than the background reference organ. In this particular case, we're looking at a tumor in the liver. So we see this is less bright than the background liver, and we call it hypoechoic. Same thing with hyperechoic. This is an increased brightness. So increased echogenicity as opposed to or as compared to the background liver. And then something that's isoechoic is, of course, the same echogenicity. Many times we can't see isoechoic lesions unless they have some sort of a border, around them, a hypoechoic border. So with that, I hope I didn't go too far over, Dr. J. Raja. I will turn it back to Dr. J. Raja.
Perfect. You were fantastic, Dr. Hagopian. Thank you so much for your overview of a really, actually very difficult topic. So, and you covered that beautifully. If there are any questions from the audience, please do go ahead and just type them in the chat box. Otherwise, Ellen, could you just comment on what we need to do to document that we've actually performed an ultrasound, and how does that work with regard to billing?
Yeah, I think that's a great question. I think that everyone should get into the habit of documenting your images. Now, if one wants to take some still images, maybe take some video and save it onto your system. Many systems nowadays do have the capability of saving images. Some systems actually can talk to the radiology PACS, and so it can be sent to PACS, which I think is a great thing because it really saves your images and documents your images. In the olden days, what we used to do is we would take our images, we would print our images, and then we would staple them to the charts. But not many of us are using paper charts anymore. In reference to, so I think it's a good habit to get into. Take at least some pictures, especially if there's anything controversial. In regard to billing, I do think that it is best practice if you are billing for an ultrasound that you should be documenting images. You certainly need to document it in your operative note. It is a procedure, and when you dictate an ultrasound, you should dictate that you've done a complete exam, you've looked at all the vasculature. This is the pathology that you found, and that certainly should be in the operative report.
Thank you very much, Ellen. I really appreciate it. Without further ado, let's move on to a specific focus over here. And Steve, if you could bring up Dr. Cho next. So Eddie is one of my partners. He trained with our group over here, and I'm so proud of what he does. He is a whiz around the pancreas and the liver, and we also do foregap here, which is crazy. So Eddie's going to talk to us about the principles of ultrasound of pancreas.
I wanted to start the talk by, first of all, thanking Dr. Gopian for a really good beginning introduction talk. And just to thank everybody that's on, taking your time to learn more about this useful tool. And I have to say I'm really honored to be part of this group because we're literally in the presence of giants in our field of HPV. I mean, we're talking really, the leaders of our surgical field, and to be part of that group is an extreme honor. So thank you very much for the opportunity. So my portion of the talk is going to be on pancreatic ultrasound, and I'm going to spend the majority of my time talking about our intraoperative work, and hopefully I'll have time at the end to show you some pictures of some pathologies that we can get with our ultrasounds. So besides the technical aspect of the ultrasound, I would find that the paramount most important aspect of ultrasounding is knowing anatomy. And I know it's funny that as surgeons, I'm talking about anatomy, but it's just another example of how crucial our complete understanding of anatomy is for the use of ultrasound. So you have a picture of the pancreas with the arterial and venous anatomy, and we use these as landmarks for our ultrasound images. And so looking at the celiac axis with the common hepatic, with a GDA branching off of that, or identifying the superior mesenteric vein, the SMV, and going up and seeing the portal vein and the splenic vein coming in, those are all landmarks for our pancreatic ultrasound. And so having that in our head, having that 3D image in our head and correlating that with the ultrasound image is crucial for our use of ultrasounds intraoperatively. So I divided my talk into different scanning techniques, but I think I'm going to just kind of skim over transabdominal ultrasound later. I will spend a little bit of time on endoscopic ultrasound because I think that's important in our field of work, and then we'll get to some pathologies. So we'll start with intraoperative ultrasound. And so, like Dr. Hagopian said, there's multiple uses, modalities of ultrasound that we use depending on the surgery, whether it's open or laparoscopic or robotic. But in kind of total, we're using a high frequency linear probes, and we're holding against the pancreas, and we're looking for good images of that pancreas, the duct, and any other abnormalities that we're looking for in the operating room. Now, sometimes we don't get as good pictures on the ultrasound machine, and so filling the lesser stack, let's say with water, improves our resolution a bit. Some people like, especially if the stomach is thin, to put the probe on top of the stomach to get a better view of the pancreas. So I generally like to expose the pancreas and put the probe right on top of the pancreas for my visualization. One of the key additions for us in our practice is a improvement in our ultrasound machine. We do use the BK in our practice, and I have to say the quality of the images is very important, and so we're very fortunate to have a machine that provides really good quality. So I was taught when I was a resident that ultrasound is an adjunct to HPV surgery, and I found out through my training and with my practice that it's actually mandatory to have an ultrasound in your room for these cases. And so our rule of thumb for any pancreatic cases is that we have an ultrasound, and we do start by ultrasounding in every case. We look for known lesions, and like I said in the beginning, knowing our anatomy, the normal anatomy, and correlating that with what we see in the ultrasound image is paramount. We generally like to use the one-finger probe. I think Dr. Gopian posted up some pictures of different transducers. So we use the eye probe for our practice. We use a narrow profile, and we kind of ultrasound the pancreas as a whole, starting from the head and going back to the tail. Some of the other rule of thumbs is that you have to know your machine and your buttons. I think Dr. Gopian went through that in depth. And then the buttons and how to actually work your machine is very important because you're going to be the one that's dictating that in the operating room. So I wanted to talk about one way of exposing the pancreas, and this is, let's say, in a setting of a Whipple procedure in which we would do for a head of pancreas cancer. And so, one of the things that we do to get into the pancreas or to expose the pancreas, because it's a retroperitoneal structure behind the stomach, is that we need to get into the lesser sac. And so, and for me, I thought let's get into lesser sac was an easy thing. As a resident, and I found that it's actually quite challenging to get into. And so when I identified this gastrocolic ligament, on the top, you have the stomach that's drawn, that tubular structure on the bottom is the colon, and that sheet-like structure in between is your gastrocolic ligament. And you're trying to incise into that to get to your pancreas. And now there should be a little bare area that you can see to get in, making sure that you don't injure the colon getting in. And our little trick is that if you have trouble getting in, we tend to go to the patient's left side, away from the greater curvature vessel. And if you go to the patient's left side, you're bound to get into a good plane where you can get into that lesser sac. One of our tricks for finding the SMV is to trace one of the veins because they all empty into the SMV. And so we're identify the greater, the gastroepiploic vein early on, or the metacolic vein early on, and we're trace that down towards the inferior margin of the pancreas. And inevitably we're run into the SMV. Now, of course, this is a very tricky and slow dissection, but once we get on the SMV, we have a landmark that we can kind of expose, that we can confirm with the ultrasound. The other challenge for our ultrasound work on the pancreas is it's a little bit difficult to push the probe into the head of the pancreas, and the reason why is your hepatic flexure and your right colon are right there. And so we generally tend to mobilize that hepatic flexure and right colon away, and that helps us to kind of expose the head of the pancreas and the duodenum a little bit better. And so a nice dissection after we kind of expose everything is kind of what you see in this drawing. And so you'll see the bile duct coming into the head of the pancreas. You'll see the SMV going up, joining into the portal vein as it goes into the liver. You may see the GDA coming off of your common hepatic artery. And so these are the structures that I look for when I'm ultrasounding the pancreas. And so when I put my probe on the pancreas and I'm looking for structures, I'm looking at the portal vein and the SMV in the long axis. That means that I'm placing the eye probe in a head to foot direction around the neck of the pancreas, and I'm identifying the vein. I can also move that probe over and look at the celiac axis and hopefully get to the splenic artery and the common hepatic artery, and I can identify the bile duct also. And so a picture of that, a drawing of that would kind of look like this, where you have the pancreas and then you have your splenic vein, your splenic artery on the bottom, your SMV kind of running right next to that. And if you can kind of remember this picture as we go to the ultrasound image, this is what we see on an ultrasound. Green is the pancreas, it's color-coded. You have your SMA and your aorta. You can see the blue IVC. You can see the little tiny dot, which is of yellow, which is your common bile duct. You can actually see your splenic vein coming in as well. And so this is a normal anatomy of the pancreas on ultrasound. So I'm going to skip a few slides here, and we're going to skip over the transabdominal ultrasound portion. And then I wanted to speak of just a tiny bit about endoscopic ultrasound, because we do use this modality a lot with our gastroenterology colleagues in identification and evaluation of, let's say, pancreatic mass. And so just a quick background of EUS is that it's an ultrasound transducer that's incorporated into the tip of the endoscope. There's two main types. There's a 360-degree and a 270-degree image probe on it. There's a balloon over the transducer tip, and that can be distended with water, and that helps to improve the acoustic contact between the transducer and the stomach wall, so you get a better image. In the close proximity between the pancreas and where your transducer is inside the stomach on the wall means that we can use this high frequency and get a very good detailed image of the pancreas, the pancreatic duct, the mass, all those kind of things. And the EUS has an added advantage of being able to do a biopsy. And so if we incorporate a fine needle aspiration or biopsy with the EUS, we can get a tissue diagnosis for whatever lesion we're going after. And so EUS is an interventional tool used by our GI colleagues. You can use it as a biopsy, you can use it as a drainage tool, you can use it as a targeting for injection. If you're, let's say, injecting the celiac plexus, for example, EUS can be an option. And so I just wanted to take a quick second to show you what an EUS image looks like. And so you can see the probe, that's the circle, and you can see the kind of the radial image that the transducer is kind of producing. And this is a normal pancreas picture that you would get in the EUS. And then this is a EUS picture of a ampullary mass. So you have the black area marked PD, which is your pancreatic duct that's dilated. And then the black arrows are pointing to a ampullary mass that's causing that dilatation. And you can see how good the resolution is. You can see the clean difference between that mass and the rest of the pancreas. You can see how we can target that with a needle to get a tissue diagnosis. And so EUS can be very, very, very useful for us. For the time that I have remaining, I wanted to spend some time just showing you some pathologies that you can see on ultrasound. And so I wanted to start with a benign disease that we see quite often, that's pancreatitis. So for acute pancreatitis, our preferred technique at our institution is a CT. There are some papers that would call for an abdominal ultrasound as a diagnostic tool to begin with, but in a case of a pancreatitis, usually the patient comes into the ER, and the usual modality that's offered there is a CT, and so that it ends up being that CT is the preferred image that we get. We do like to use ultrasound, especially if we're thinking that this is a gallstone pancreatitis, to see if the disease is triggered by the gallstones. Just remember that in mild pancreatitis, we're not going to see usually an ultrasound evidence of anything that's going on. And ultrasound is not as great in terms of depicting necrosis or hemorrhage, and that's another advantage of a CAT scan in a setting of pancreatitis. But if we're looking for complications of pancreatitis, and if we're also looking for ways in our surgery to help us while we're in the belly, let's say, of a patient that's had a history of pancreatitis with a complication with now symptoms, then ultrasound becomes hugely important. And so this is an ultrasound of a patient that has developed a complication. On the right, you see a CAT scan with a pretty walled off fluid collection. And according to our revised Atlanta criteria for pancreatitis, then this patient is probably more than 4 weeks out based on the walled offness of the fluid. You would either call this a pseudocyst or a walled off pancreatic necrosis. looking at the debris. And if you look at the ultrasound, it actually shows on that star to the right of the ultrasound a pretty homogeneous kind of area. That area kind of looks like a pseudocyst, whereas the area that's depicted with the white arrow looks heterogeneous with debris inside, and so that looks like to me more of a walled-off necrosis. Here's a picture of chronic pancreatitis. And in chronic pancreatitis, one of the changes that we would see are irregularity of the pancreatic ducts. We could see some inflammatory masses, and we could see some calcifications. And the inflammatory mass can be a problem, right? Because these regions can be cancer. But findings of calcification within these masses can help us say, maybe this is chronic pancreatitis rather than carcinoma in terms of etiology. We also see ductal dilatation, maybe in about 5 to 10% of the patients with chronic pancreatitis. And so that is useful in terms of ultrasound screening also. And there's an entity called autoimmune lymphoplasmacytic pancreatitis, autoimmune pancreatitis, which is kind of characterized by these like histologically fibrotic changes with lymphocytic infiltration, as the name suggests. And on ultrasound imaging, the gland looks diffusely swollen, the main duct is irregularly narrowed, and these pancreatitis are kind of cool to diagnose because the patients respond very well to steroids in terms of treatment. Probably the last thing I wanted to cover before I am done talking would be solid neoplasms of the pancreas. And so I wanted to kind of give you guys a picture of what a pancreatic adenocarcinoma would look like. So the bile duct is labeled BD. You can see the vein and the IVC. And based on where the bile duct looks, you can see that the transducer is, the eye probe or the transducer is oriented up and down, head to feet. And you can see that mass that's labeled M and also has big, bold, white arrows on it that's blocking the bile duct. And so you have a dilated bile duct because of this mass. And then if we take the same patient and we look and we change the orientation of our probe, and now the probe is aligned so that it's going left to right, like along the orientation of the pancreas, you can see the big white arrow, which is a dilated pancreatic duct. And so in imaging world, the dilation of both the pancreatic duct and the common bile duct is known as a double duct sign. And for us, it's always a suspicious imaging finding for pancreatic adenocarcinoma. And so these two pictures kind of depict that fairly well. I can use the ultrasound during the operation to look for the mass or to identify the mass. I can look at it to see its relationship with some of the crucial vessels, let's say the superior mesenteric vein, to see how close it is, whether it's invading or not, that of that nature. I can also use the ultrasound as a targeting agent. So sometimes we use what's called irreversible electroporation, which is it's loosely described as a non-thermal kind of ablation method. It's really not ablation, but it's a way of, but we need a way to target that probe into the mass without getting into some of the crucial vascular structures. The whole idea of it is to what we call margin of saturation, or try to get the mass away from the crucial margins, like the margins to the blood vessels. And so we would use the ultrasound as a way of targeting that probe so we can insert it around the mass but not get into one of the crucial vessels and cause a horrific hemorrhage in the operating room. So that's kind of what I have for pancreatic ultrasounds. Again, as we go through the talk, if there's any questions or anything you want us to address, just please type them on the chat. And if there's nothing further, I'm going to hand over the microphone to Dr. Jayaraja. Thank you so much for the time.
Thank you so much, Eddie. I really appreciate it. Eddie, do you have any thoughts about how you could use pancreatic ultrasound for targeting in specific cases?
Yes. So I mentioned just very briefly at the end about this concept of irreversible electroporation, or IRE in short. And essentially what you're doing is you're placing two probes in a kind of parallel direction, and you're basically creating an electrical field between them. And for, let's say, masses that are very, very close to some of our blood vessels and whatnot, we can use this technique for what we call, again, margin accentuation. But we need a way of targeting these probes to place them in a correct orientation, correct distance, things of that nature. And our ultrasound becomes an exceptional key in terms of that. And so that's like one example of a targeting method, ultrasound being an important tool and a targeting method for pancreas.
Perfect. Thank you so much, Eddie. I really appreciate you putting together that nice talk. Next, let's move on to my dear friend Erin Berber, who's a professor at the Cleveland Clinic. Erin does a ton of laparoscopic and liver work using ultrasound, and thank you very much, Erin, for agreeing to give us a talk on the principles of liver ultrasound.
Thank you very much, Ron. I really appreciate this nice webinar here. So liver ultrasound, we should first recognize the tools that we have regarding transducers. We'll touch on both open and laparoscopic surgery. For open, pretty much the transducers that we have, and again, I don't have any conflict with any of the ultrasound companies, and every company has similar products. If you look at the transducer we have on the right-hand side, you're going to see a large curvilinear ultrasound transducer that's mostly used for percutaneous ultrasound that we surgeons don't actually use too much. But I'll tell you if you were to use how you would use it. And then ones on the left are more for intra-operative ultrasound, or if you're doing more high-frequency ultrasound where you need a significant resolution like breast or thyroid ultrasound, you can also use these probes. But these probes are pretty good for intraoperative ultrasound as well. So if you look at the transcutaneous ultrasound, you should be familiar with some of the standard planes. Right lateral longitudinal plane will give you a window into the liver and also to kidney. This is one of the standard planes we use for the FAST exam, and if the patient has intraoperative bleeding, you will see blood collecting between the liver and the kidney. Then if you move the transducer to the right, to the left of the patient, it's called the right paramedian longitudinal, you will have access to the liver, portal vein, and the IVC. And if you look more towards the chest wall by angling the transducer towards the costal margin, then you will have an access to the liver, and this is a good view to look at the hepatic veins. Likewise, you can hold it parallel to the costal margin, and then this will also give you the same view. If you have the patient take a deep breath, then you should be able to have a good window to the hepatic veins as they join the cava. You should know the two separate techniques that are useful both for open and laparoscopic ultrasound. The first one is the contact scanning. And for the contact scanning, you place the ultrasound transducer right on top of the liver. You're seeing that I'm actually using one of the laparoscopic transducers to scan the liver. Don't be surprised about this, especially if you're doing interventions, as Dr. Iannitti will talk later, sometimes having a laparoscopic transducer becomes handy, especially doing biopsies or ablation procedures. So keep this in mind. But you can place the transducer right up on top of the liver without using any coupling medium. And as you can see, then you can have a nice view into the liver, as you can see on the ultrasound image. This is another view of contact scanning where you have one of the ultrasound probes I showed you. You just use a sterile ultrasound cover. You want to make sure that you place some ultrasound gel inside the cover so you can use any of the external transducer on the liver. And this is showing the video about the contact scanning. But you'll see that one of the drawbacks is going to be if you don't have a good contact, like you've done some resections and you're looking at the resection bed, then you will get into some artifacts. That's when the standoff scanning technique becomes handy. Standoff scanning technique is where you use an intermediate medium between the transducer and the liver. The idea is to be able to see the edges of the liver more clearly by using the water to look through. As you can see, when we're looking at our metastasiectomy bed, by using the saline, you are able to see your resection bed really well, and you can really have an idea about if you're leaving any residual tumors or not. Showing this on the video, again, you want to fill the right upper with some fluid. Make sure you don't have a lot of bubbles in the fluid, and then you can use any of the transducers, and you'll really have a nice view into the edges and into the surgical resection bed as well. Laparoscopic ultrasound techniques use the same type of approaches that I showed you. The laparoscopic ultrasound transducers, again, they're produced by a lot of different companies. They are either rigid linear side viewing, or they would be flexible side viewing. Every surgeon has a different preference to use whether a flexible or a rigid transducer, and then based on your experience, over time you will see that you form some preference for one of these transducers. Definitely, if you have limited in space, the flexible probe is perfect to be able to give you a diagnostic view, whereas the rigid one becomes handy if you're practicing needle placement techniques, as Dr. Ioniti will talk later on. The technique requires the placement of the ultrasound transducer through a 12mm trocar. And in order to look at the liver, you can use it in the epigastrium or in the right upper quadrant, but you have to keep in mind how far the liver comes down so that your trocar will be as low as possible for you to have direct contact with all segments of the liver. If you have a flexible transducer, this will be less of a concern, but if you have a rigid transducer, you have to select your probe site really well. Generally, what I do is, with my initial entry for the camera, I take a look around and pick the best spot for the ultrasound trocar. Obviously, you can move the ultrasound transducer to the other trocar as well. There are two techniques. Again, if you want to look at the liver, you can either do a long mowing technique, where you place the ultrasound right on top of the liver and just linearly scan the whole liver, which is easier. Or you can follow anatomic structure, which might be a little bit difficult initially, but as you get familiar with the anatomy, you might like this technique a little bit better as well. To give you an idea, when you have the ultrasound transducer, you place it into the abdomen, the ultrasound needs to be plugged into the ultrasound machine, and you have to select the probe that you're working with. And again, every machine has similar principles, and you can see the image is not good because, as Dr. Hagapian mentioned, you want to increase the gain. And as you increase the gain, you'll see that you'll start recognizing the liver parenchyma better. So you adjust it to a setting that you like. And then these are the focus buttons. You can also move them up and down depending on how what the area of interest for you is. These are the type depth compensation buttons here. And then you also adjust them to make sure you have a homogeneously bright image on the screen. And afterwards, you will be pretty much ready to scan. The picture-in-picture is a very good feature to use if you have the ability. You just need to pass either DVI or S-video cable from the ultrasound to your laparoscopic tower, so you can actually have this image, picture-in-picture with the laparoscopic image. These are some other images of the contact scanning, and you can apply it for the pancreas or the liver. And then this is showing the standoff scanning, where you have to use the saline to look into the capsular edges of the liver, and you can really see the detail provided by this move. And this is showing another case. This patient has a tumor in segment 7, but it's not very clear at initial look, but with the saline standoff, it becomes very easy to see. With the long moment scanning, you basically start, you can form your preference. You can start from the right lobe, or you can just start around the falciform, go in one direction, then pull back 3 centimeters, go the other direction, and see if your eyes catch any irregularity or any abnormality on the liver. As you can see here, again, there's no rule about this. It's just you want to make sure that you cover all of the segments of the liver with this, and you just have to make sure you have a good angle so you can place the ultrasound transducer right on top of the liver. Sometimes for the anterior segments, you might have to place the ultrasound transducer inferiorly if you cannot have good contact. And then this is the technique of anatomic scanning, where you start at the portal vein at the hilum, and you can use duplex to figure out where the bile duct and hepatic artery are. And then if you trace it to the right, you will see the portal vein branch is going to the right, and then you go towards the left, and you can see the left portal vein is easier to identify. And then if you go towards the umbilical fissure, you're going to again see the branches going to individual segments in the left lobe. And this is pretty actually easy to learn. The biopsy techniques, and Dr. Aine will go into that. One important thing, just want to emphasize, make sure that the ultrasound transducer is in plane of the needle is in plane of the ultrasound transducer, so you can see as it goes through the parenchyma. And there are a lot of different biopsy devices available. You should know how they function. And then knowing these principles, then you will be ready to do also interventional procedures such as ablation, again, which will be covered by Dr. Ioniti. Thank you.
Aaron, thank you very much for that lovely overview of the liver and some great pictures. Last but not least, I want to introduce my dear friend David Ioniti, who is a dear friend of mine. We share many things in common, including our love for cooking. And David is really extremely fond of laparoscopic work in general, and gets on me all the time for doing any open cases. But here we are, David, if you could talk to us about the use of ultrasound for ablation. Thank you.
So I'm at Carolinas Medical Center here in Charlotte, North Carolina, and the disclosures I have is that I have consulting agreements with pretty much all the ablational technology companies. And as Dr. Berber and Dr. Gopian have been saying, that it's been certainly a significant evolution of ultrasound machines, as you can see here, a little bit some of the older ones, and to the more modern machines that have a variety of bells and whistles, including high definition, color flow monitoring, Mode+Doppler, and things that we use pretty much in our everyday surgery. As Dr. Cho was saying, I think that it's certainly a very good habit to try to get into using ultrasound pretty much on a regular basis, so that not only are you, the user, comfortable with the use of ultrasound, but also the staff in the operating room also need to be comfortable with making the manipulations and color and B mode and depth and gain and all that sort of stuff. So there's lots of advantages for using ultrasound on a regular basis to get everybody used to it. As Dr. Berber said, there's a variety of probes out there, and the common probes that you're going to use are the T probes, transabdominal probes, and we use a lot of the vascular probes in open surgery. But again, we're trending much more towards minimally invasive surgery. So we saw some of the older laparoscopic transducers, but the modern transducers really have a large degree of freedom and flexibility for flexing left, right, up, and down. And for those interested in robotic surgery, there is a robotic drop-in probe that can be used laparoscopically as well. And these, again, are very high-resolution probes that work exceptionally well. They're also very expensive and very delicate. Each probe costs probably around $35,000 per piece, and it's easy to break them. So we just assemble these fairly simple, relatively inexpensive trays for processing of the probes, since we use the probes in a sterile fashion, and it definitely decreases on breakage rate significantly. Now, when you pick up an ultrasound probe, particularly for targeting, there's a few things I think it's important to do. One is orienting your probe. And I would strongly suggest that every time that you pick up a transducer, that you orient that probe, because it's amazing that you may not realize that the probe is not oriented the way you want. So you can see we just switched left-right there. And you're trying to figure out in your mind, you know, what's going on and why you can't target it correctly, and it's because the probe may be reversed. And you can see that we're going caudally or cranially in this orientation. However, we may flip that probe 90 degrees, and therefore you may want to flip your image. So it's important to be disciplined to test your orientation of your probe pretty much every time you pick it up. As Dr. Berber mentioned, there's a few different techniques, and the point I'd like to make here, regardless of the technique, whether it be a lawnmower technique or whether it be a pedicle tracking technique, is that when you're ultrasounding an organ, just like if you were looking at a CAT scan, it's really most important to be disciplined and to evaluate the entire organ before putting your eyes directly to the pathology itself. Sometimes it's useful to look at the pathology first, to look at the echogenicity of the tumor relative to the background liver or background pancreas, which can be helpful. But again, being thorough and disciplined in mapping out all of your lesions, all of your vascular structures before you start with any interventions. Now, there's a variety of things that we do as surgeons for targeting, as you can see here on this slide. And again, we're going to focus more on targeting for the purposes of ablational procedures. And this is just an off-the-beat example of an ablational procedure where we're actually percutaneously targeting the umbilical cord of a trap sequence partially formed fetus in an attempt to thrombose the vessel with microwave ablation to cut off the blood supply to the trap sequence to help the contralateral formed twin. So when it comes to targeting itself, you know, there's several points that I want to make. One is covering transducer positioning. Another is hand positioning. Talk about angle of approach, as Dr. Berber had mentioned, and very briefly touch upon some of the advanced image guidance systems and how they've developed over the past 10 years. So when it comes to transducer positioning and targeting, a common thing, particularly if you're doing an open technique, is that we tend to be very focused on the ultrasound aspect of it. And sometimes if you're using a needle for ablation, as you can see here, or targeting, that sometimes your angle of approach may be limited because of a variety of anatomic structures. And so I would suggest that when you're using ultrasound for targeting, to rotate your ultrasound hand, as seen here, so that it gives your targeting hand, whether it be a biopsy needle or a microwave needle, the greatest degree of freedom so that you can better access your target. Another important thing, I think, is that particularly when you're using open ultrasound, is being able to physically connect your mind to the transducer plane itself. As we know, the transducer plane is sort of like hanging a sheet of paper off of the ultrasound probe. It's a very thin plane. And when your hand is back on the cable or back on the transducer itself, then you're a little bit disconnected from the transducer itself. So I'd also suggest that putting your fingertips directly on the transducer sort of physically connects you to that transducer plane and can help you with 3D orientation and spatial location. So when you're targeting in an open fashion, I think there's a couple of different ways that one could approach this. You can put the target between your fingers here and then project in your mind. You say, okay, that target's 3 centimeters down between my 2 fingers, and I'm going to pass my needle to that point in space between my fingers. Everybody's different. I personally like to have a target below one of my fingers, looking at the information on the screen, 3 centimeters, 4 centimeters down, and then I try to put a biopsy needle or an ablation needle deep to my finger at that location, and that's sort of what's going through your mind as you're trying to target itself. And this is obviously a very old video of doing an open ultrasound. As you can see here on the cirrhotic, fingertips are on the transducer itself, and we'll go ahead and targeting the lesion for biopsy purposes here. And again, the biopsy hand is given the maximum degree of freedom for targeting purposes. So as Dr. Berber mentioned, angle of approach is very important. The biopsy needles and ablation needles that we use are fairly thin, and the transducer plane is also fairly thin. And ideally, you'd love to have your needle in the plane of the ultrasound itself so that you can see the length of the needle and have more control of that needle as you're passing it through the parenchyma of whatever organ you're trying to target something. So when you're in plane with the transducer, then you're going to see the needle in its length. So here's an example of targeting a small, I believe this is a colorectal met. Here's an ablation needle coming through in plane, and you can see the needle pretty much the whole way going right through that target. Now, the more out of plane that you go, then the less of that needle you're going to see in your ultrasound plane, and so you start limiting your visualization. As you can see here, you have a very small window here to see the needle itself, and it's very important. So as you're rotating your ultrasound hand and you're sliding back and forth, you're always trying to keep your tip. You know where your tip is at all points in time as you're advancing through the parenchyma. And certainly the worst case scenario is if you're 90 degrees out of plane. Now, sometimes we target things out of plane intentionally. So say you're doing a vascular stick or something like that, then we'll use the information from the ultrasound in depth and left to right location, and that can help angle your needle. The disadvantage is as you're moving a needle, you have no sense of motion of that needle itself. And so really the strategy there is to go continually follow your tip. So you're moving your ultrasound probe from your tip to your target, to your tip, to your target, back and forth, as you're guiding that tip into the target. And that's probably the most difficult way. That's the same video. It's the most difficult way to target things, but again, it's sort of more in line with reality. So you can see here you have no sense of depth, and so what you do is you slide your ultrasound probe as you're moving the tip of the needle. Now this sort of just quickly puts it all together. This is, again, an old video. It's an open procedure with a 915 megahertz antenna, which we don't use anymore. And again, we're using a clustered microwave array here to target a large neuroendocrine tumor. We're trying to keep the probes in line. You can see we have a variety of ultrasound probes here on the field itself. And you can see here's a large lesion here, and we're passing the needles to the deep margin. And this is what you like to see on ultrasound, is your needle in plane, and you can follow your tip, and based on the antenna design that you're using, bring that tip either to or just past the target margin. Now, as I mentioned earlier, we tend to be a lot more minimally invasive, and that's certainly the trend throughout the United States. And so laparoscopic targeting could actually be even more challenging than open targeting. Well, why is that? Well, because we have a lot more variables to deal with than open targeting. When we're doing open targeting, you're directly looking down at your hand. That's certainly very nice. But laparoscopically, the laparoscope may be in the flank, it may be down in the pelvis, it's a variety of angles and views that you may be getting. Your hand location, unfortunately, is not directly on the organ itself. It may be 30 centimeters away, so your hand's away back. The instruments that you're using are much longer. The laparoscopic probes are probably 35 centimeters long. Your microwave antennas are, 25 to 30 centimeters long, so much longer instruments. So you're starting to lose that physical connection between the tip of your applicator and your ultrasound plane. It just takes repetition and experience to sort of regain that. When we're dealing with angle of approach, I would say that it's probably more common than not, laparoscopically, that you're sticking your target out of plane. And that's just for about 1 million practical reasons. So you need to be used to targeting out of planes. And then finally, when you have an open abdomen, you could have a lot of manipulation of your needle. But when you're doing it laparoscopically, you're essentially dealing with 2 fixed points. You have the abdominal wall itself, then you have an air gap, and then you have the organ, whether it be the liver, the pancreas, or whatever. And so really, to target something deep in the parenchyma of an organ, you actually have to have your angle of approach almost perfect from the point where the needle is entering the skin, because your ability to move and steer is profoundly more limited laparoscopically than it is open, particularly on a heavier person. So, really what you need to do as a surgeon is to assimilate all of this input that's coming at you. You've got to assimilate your visual data, which is your laparoscopic picture view. You have to assimilate the picture that you're getting from the ultrasound view, but then also appreciate in 3-dimensional space where that transducer is, the angle of that transducer. Is it coming back to you? Is it straight down? Is it left? Is it right? And you need to pull that all together so that you can visualize that target in 3-dimensional space. So where is that target in space relative to me, and where is the tip of my needle? And really, when you're targeting, what you want to do is you want to direct the tip of your applicator, or the microwave antenna, into the target. But rather than using the images on ultrasound and laparoscopy, you're really using all that data to figure out where that is in 3-dimensional space. And it's actually your proprioception of the tip of the needle and the 3D visualization of where it is in space, and bringing those 2 points together as your primary driver of your motion. And then for refinement, for the small moves, that's where you look at your visual inputs, including your laparoscopic view, but most importantly, your ultrasound view. So it's certainly much more challenging to do that. And let's see if we've got a couple of examples for you. So this is an old school 245 microwave antenna. And you can see here's a nice little target here in the liver. I think the microwave antenna is bigger than the target itself. You can see that we're trying to stay in plane as best we can. And again, in plane, we're able to pass that needle through the fatty liver parenchyma here into or bouncing off of that lesion itself, so that we can carry out our ablation. Now, one of the things that we figured out with microwave is that you can actually visualize the effects of the microwave near field in real time by using color flow monitoring set at a scale of about 8 centimeters per second. That's usually pretty good for most livers, I should say. And I can talk about that if we'd like in the discussion. Now, when you're going to ablate something, as I mentioned, what you want to do is you want to thoroughly evaluate the organ first. You want to sort of ignore the pathology. But as you're identifying new lesions, because as we all know, intraoperative ultrasound in experienced hands is the most accurate way for detecting lesions, particularly in the liver. You want to sort of call out to your circulator, okay, segment 7, I have a 1 centimeter lesion. Segment 6, I have 2 lesions. One is 1.5 centimeters, one is 5 centimeters, one's medial, one's lateral. And then what we do is we create an ablation sheet. And this is very practical. This is ours, but you can certainly do whatever. But the whole goal is to be thorough and complete. And you can see here we mapped out 10 lesions. You can see the location, you can see the size, and then we also document how much power and how much time we used, and that all goes in the operative note. And I think that's a nice, effective way to do that. Now, again, we have various angles of approach from out of plane to in plane. Now, sometimes when you're doing things laparoscopically, the targets can be relatively small. And if your transducer is sitting over the target, it may be knocking your needle out of the way. So one strategy is to slide your ultrasound. You know the angle where the target is. You can slide your ultrasound over to the side. This is just more of a cross-sectional view. This is when missing. You're looking at the lesion, but you can't hit it because your needle is getting bounced off of the ultrasound's transducer. So what you can do is move the ultrasound off to the side, angle your transducer, and then pass your needle down the plane where the transducer was into your target. And this is just a laparoscopic example of that. You can see there's the needle. I don't know how well that projects, actually. And basically what we're doing is we understand where the target is with the ultrasound. We slide the ultrasound transducer over, and then we can pass the needle. I have better videos I can show you in a sec here. Now, the other thing that you can, with the ultrasound, is a needle guide. And you can see that you have this little hole here. And that hole is for a needle guide, and it's at an angle of about 45 degrees. And so you can project that needle guide onto the ultrasound, as you can see here in about a second. Here comes a needle. Now, if you're going to go through the needle guide itself, it has to be perfect. You can't force it. The angles have to be correct. And you can see with the needle guide, here's the target between two vessels here. There's the little yellow dots of the needle guide, and that gives you a pretty good estimation of where the needle's going to go. It's never exactly perfect, so now I can guide that needle right between two vessels and take the biopsy or do an ablation or whatever you need to do. Here's just a lesion in the back here, and showing a couple more tricks. This is a soft liver, something I almost never see. And there's a lesion back here in segment 6. Now, one of the things to sort of get your angles of approach good is you can see I'm using a grasper here, and I'm just sort of bouncing on the surface of the liver, trying to get a feel for the angle. Now, my transducer is rotated 90 degrees and flipped, sort of counterclockwise, so that all those angles are off. But getting a guesstimation of that angle outside with a grasper is a good idea, and that gives you sort of your gross moves. And then you can refine your moves, as you can see here, with the use of ultrasound. And we're relatively in plane. The tip went to the end of the lesion, and you can see the microbubble formation that you get when you're carrying out an ablation itself. And we can usually see this with color flow monitoring. Hopefully I put that on. There it is. And that right there is the effect of the microwave near field. Doesn't correlate with the final ablation volume because there's a conductive zone afterwards that will expand that zone itself. But using the color flow monitoring is very important because you can get a sense of where that microwave near field is. And then finally, when you're doing targeting, when you're dealing with larger lesions, if you're not doing multi-probe ablation, then you generally want to do overlapping zones of ablation. So typically what you're going to do is target your lesion deep and medial first, then start ablating, and then carry out your ablation by going up and out. So if you ablate on the anterior aspect of the lesion first, then that microbubble formation is going to obscure your visualization and you won't be able to see later. So you can see here the microbubbles are in the back. And then again, we'll do overlapping zones of ablation with this particular system to work our way up and out. And then as Dr. Berber mentioned, a step-off technique I think is very useful. So we're ultrasounding the liver, everything looks good, and what we're doing is we're filling up the abdomen with fluid. As you mentioned, you don't want a lot of bubbles, you don't want it to look like cappuccino. And you can see with a standoff technique or a step-off technique, now you can see a small surface lesion that we probably wouldn't have seen if we just used a regular ultrasound technique. So the standoff or step-off technique is very valuable. You can see we also use it when we're targeting a lesion, and then we can carry out our ablations. So we're not missing any lesions, because certainly we're doing a patient a disservice by not identifying all the lesions that they have and treating them appropriately. And just to wrap up for the last couple of minutes, you know, targeting can be very difficult. And so over the past 10 years, we and others have worked on advanced image guidance systems to try to make targeting a little bit easier. Now, one of the systems that was in early use was a CAT scan-based targeting system called Pathfinder. I don't think it exists anymore. And you have a variety of views. And basically what it's doing is fusing the DICOM, looking at surface mapping the liver in a variety of ways, and then conforming the DICOM, and then using the DICOM as the modality for targeting. Now, there were some restrictions with this in terms of accuracy, and that's being worked on. And to try to overcome some of that accuracy, there has been conforming the DICOM with ultrasound registration of the major vessels, and that's called calcination, which is fairly popular in Europe. This was the first case done in the United States. And again, lots of limitations with overhead infrared cameras and whatnot. Over the past 10 years, we've worked on a real-time advanced image guidance system. You can see this is our prototype model version 1.0, again, 10 years ago, working on targeting and then creating a virtual reality needle, as you can see in this very old video, overlaid on the laparoscopic view and overlaying on the laparoscopic. And here's the ultrasound view here itself. And this is what we see is you have the regular ultrasound view, the ultrasound view floating around in 3 dimensions, and then actually a virtual reality representation of the needle. We've demonstrated in, with the older system and the updated laparoscopic system that for every level of user, that it certainly increases your accuracy significantly. This is one of my favorite videos of all time. This is using a system on a neuroendocrine tumor, and the video demonstrates a few things. One, the incidence of occult disease not recognized on wonderful preoperative imaging. We could see a couple of lesions that weren't identified. So I think of laparoscopic enhanced staging with intraoperative ultrasound, I think is very important for patients that you're treating malignancies. And then you can see the limitations of percutaneous ablation, where it's a partial ablation because they're afraid to burn the stomach. Laparoscopically, obviously, we can move things out of the way so we can carry out more effective ablations. And then basically what we have on the ultrasound probe is a electromagnetic directional field detector, which were built into the antennas themselves. And this trajectory here is the trajectory of the needle. And the purple swirling things are where the trajectory crosses the ultrasound plane. So we can line up the purple box, and now it's a green box or a green oval. The oval represents 95% confidence interval of where that needle is going to go. And so then we can pass our needles through the abdominal wall, through the parenchyma, and this is actually a virtual reality needle. So you can see how the liver deflects in real time when the needle goes through, and then we can adjust our time and power based on what we would like for a final ablation volume. And then we can go ahead and carry out our ablation. And you can see with color flow monitoring, we can monitor the ablation itself as we're carrying it out. So we looked at the most recent system that we developed, which is now available. And we looked at, this is a very busy slide, novices, intermediate, and expert level users using gel targeting. And for really all the important metrics, time to needle positioning, you can see significantly different for all levels of users with standard targeting versus advanced image guidance. If you look at number of misses, significantly lower for all levels of users when you use advanced image guidance versus not. So in summary, I think that ultrasound is absolutely essential, not only in HBB surgery, but a variety of general GYN, GU surgeries. I think it's important to be disciplined in mapping out your entire organ, liver, pancreas, biliary tract, whatever it is, and identifying all the lesions, pathologies, and vascular structures. And you can do that through a variety of techniques, including the lawnmower technique, pedicle tracking, and others. Targeting techniques certainly can be challenging open and particularly laparoscopically. And I personally believe that advanced image guidance targeting systems are going to be the norm moving forward. So with that, I want to thank Dr. Jayaraja and everybody for allowing me to talk a little bit about a topic that's certainly near and dear to my heart. Thank you.
So we don't have a lot of time, but I was wondering if we could just go ahead and I'll get the group to discuss a few cases here and ask for some opinions, but also ask about the opinions about the medical management, but also about the use of ultrasound. So we have a 57-year-old female who had a severe acute necrotizing pancreatitis in July of 2018. She was in the ICU, not intubated or on dialysis, and was managed by another surgeon who took her to the operating room. This was presumably biliary pancreatitis, so gallbladder was removed, and she was also underwent an open debridement procedure. Dr. Cho, what circumstances would you consider performing a debridement in a patient with acute necrotizing pancreatitis?
Almost never. We would, the only time that the patients, so the two surgical operations that are in the book in terms of acute pancreatitis for surgical management are if the patient develops a compartment syndrome or if there's an affected necrotic collection in the pancreas that's not amenable to endoscopic drainage. But in a patient that has pancreatitis, our usual norm in terms of our practice is to not operate on them for as much as possible and give every other opportunity for the patient to either try conservative management or endoscopic management or some sort of a non-surgical management for those patients.
Thank you, Dr. Cho. So this patient subsequently, at the time of debridement, had a drain placed and basically came to us with a chronically draining area with a drain in place that was draining between 100 and 200 cc's a day. The amylase in the fluid was basically pure pancreatic juice. I have a CT over here to show you. And you can see, I'm jumping a little bit, but you can see that this is the area where my pointer is, that you can see sort of puckering of the gland, and the drain is sitting right here. So again, just to go through these images, we've got this circumstance. So Dr. Ainetti, how would you approach this?
I'm just trying to get a land here. Are you trying to say that you have a disconnected pancreas?
Correct.
Okay. All right. So, after you go through the acute event, then typically if you have a body and tail disconnected from the head and neck, and the body and tail are chronically putting out pancreatic juice, and typically we would do one of two things. One, a distal pancreatectomy to just get rid of that segment, or if that's not technically possible, then put a roux onto the fistula.
Okay, perfect. Dr. Hagopian, any other thoughts?
No, I agree with that approach. I think that this is an extremely difficult problem, and I think that even a distal pancreatectomy would probably be really difficult in this setting. So probably a roux would probably work best.
Oh, yeah, no, very nice. So we actually looked at our experience with cyst drainage, which can end up with a similar circumstance because the gastroenterologists have popularized before they started to do endoscopic cyst drainages that these patients end up with a disconnected duct. And Eddie, I think you did this study. What did we end up finding with regard to the percentage of patients that needed distal pancreatectomy after a drainage procedure?
It was high. That was surprising for us. And so the obvious question that came out from that paper is a drainage procedure even necessary? I mean, should we be skipping straight over to a resective procedure rather than a drainage procedure? And so in a percentage of patients with a cystoscopy that required distal pancreatectomy, our number was about 20%. It was like 17.6%, something like that. So about 20%.
Okay, so that was, I guess, one of the thoughts as we went into this. I was also petrified because this patient had I didn't really show it very well, but the SMV is out, and there was some huge collaterals in the left upper quadrant. You can kind of get a sense as to if this is all junctional varices over here. Her platelet count was 77,000 also. So what I elected to do in this case was to I like to study the head to make sure that there is no leak from the head, and make sure that they've cut a sphincterotomy, which we did. And then, interesting enough, I shot the drain, and it filled the distal duct. So we, in fact, have a truly disconnected duct over here. And just as Dr. Hagopian and Dr. Ionetti said, I have sewn a rulum to the drain tract, basically. And that can be helpful to try to get out of Dodge. I was planning a distal pancreatectomy, and as was mentioned, and so I actually went out and did a angiogram pre-op and embolized the splenic artery. David, you're smiling. Any comments for the group?
Well, I see the direction you want to go in is a distal pancreatectomy with splenectomy because of the left-sided portal hypertension. So you can either do that preoperatively, as you did, or one of your first maneuvers is to try to get that splenic artery.
Right, right. And that's what I usually advocate, is just go to the left sac, get the splenic artery, and then begin your case. The reason I thought a pre-op embo would be helpful would be because of the platelet count in this patient. And I always state, and maybe Ellen, one of the things that I always teach our fellows is that it's surprising that I always feel that you need central portal hypertension in order to have thrombocytopenia in the face of sinestral hypertension. So in a patient with left-sided portal hypertension, for example, a splenic vein thrombosis in the face of chronic pancreatitis, or acute pancreatitis, it's rare that we see thrombocytopenia in those patients. So I was bothered by the low platelet count in this patient because I thought it maybe indicated more central liver disease. Ellen, thoughts?
Yeah, I think that's a very good point. No, you wouldn't expect to see thrombocytopenia in left-sided portal hypertension, not at all. So I would be concerned about some sort of underlying disease. Could be hematologic, could be something that's completely medical, or could be something hepatic. But I would be probably more concerned about some sort of medical reason for the thrombocytopenia.
Okay. So actually, this is the coiling, which was not terribly helpful. And so I just wanted to show an example of how ultrasound helped me here. So just to start out with our ultrasound, what I'm showing over here is actually, this is the location of my drain, which I actually couldn't even feel to begin with. We then went on, and let me just go out with this. This was looking at this is transgastric, I believe, is what we were doing over here, and this is our distal artery over here that was occluded. We then went on to look at this pancreas. So this actually was a segment of pancreas over here that was very normal. And you can see normal pancreatic parenchyma over here ending where this drain goes in. again, just to show normal pancreatic parenchyma that ended right at the disconnected duct over here. So, Aaron, what are your thoughts about this case?
You know, very nicely done. You know, it's a complex pancreas case. You know, I don't do a lot of pancreas cases nowadays except for neuroendocrine tumors, but I think this has been really nicely done, and you use ultrasound really nicely.
We needed all the help we could get, Aaron, because this patient lost quite a bit of blood at the time of this operation. I think, you know, from my old portal hypertensive days, that junctional varix really got us at one point, but we were able to get this under control. Interestingly, you know, Ellen, I was as concerned as you about the platelet count, but the platelet count has risen to like 200,000 post-operation, so I'm actually happy about that. I've always said, you know, that you need more than sinestral portal hypertension to have thrombocytopenia. Dr. Cho, any comments about this case?
Yeah, just for our younger audience, I can't, I have to adequately say how scary the surgery is in terms of the collateral vessels and the bleeding that you can encounter from this. This surgery can be quite scary. And so I think Dr. Jayaraja pointed out a really nice way that ultrasound helps us in terms of that, identifying exactly where we want to go in terms of our resection and those kind of things, and kind of identifying all the anatomy outlines before we actually commit with our surgical bogey and whatnot. But this surgery is extremely scary. I've seen like a lot of bleeding coming from this. Part of a line.
Yeah, no, thank you, Eddie. There was a lot in this case too. All right, let's move to another case. So this is the case we just did, a 50-year-old gentleman who actually presented with anal pain. Now, how this has anything to do with HPV, one could wonder. But he was found to have a perirectal abscess, and finally, after some effort, was actually finally diagnosed with an anal canal squamous cell carcinoma. Staging workup was negative. He underwent standard NIGRO protocol in July of 2018. A colostomy was placed at that point due to really rectal pain and discomfort, and subsequent anal mapping was negative. He had a follow-up PET scan with a negative pelvis, but the liver had some uptake in the right side of the liver. So he's basically a year out from his NIGRO protocol. This is an MRI with EOVIST. Those of you that know me know that I'm a huge fan of MR for liver. And I think in the current era, EOVIST and diffusion-weighted imaging is critical. So here we are. You can see that there are some lesions in the posterior right liver. Just for our trainees, important to see the right hepatic vein, middle hepatic vein, and left hepatic vein over here. So this segment would be between segments 7 and 8. And these two other lower density lesions are in the posterior right liver here. So just wanted to show this to you, and again, I think this is, I don't have all of the cuts, but this is right portal vein, and again, a lesser hepatic vein over here. So he had actually done well tumor-wise. Dr. Hagopian, how would you approach this case? Biopsy, by the way, shows squamous cell carcinoma. Sorry.
So just to recap, so squamous cell carcinoma, he had NIGRO protocol, and he
correct.
And he is now, as far as you can tell, free of disease. And he had no further. I'm sorry, I got distracted. He didn't have any other surgeries, free of disease, and from the anal cancer standpoint, except for these questionable lesions.
Well, they're real. They were biopsied and were squamous cell carcinoma. I will also add that I took him to the operating room and personally did an exam under anesthesia. His perineum is a mess. He's got a big posterior ulcer in the rectum, and that's why I think he's having so much pain. He also, I biopsied everything externally and in the canal, and they all came back negative.
Yeah. So, yeah, I think you have to be, what I was getting at is I think you have to be careful with this particular disease. You know, when it metastasizes to the liver, It does not usually just go to the liver, and it's also not very commonly, it does not commonly go to the liver without lymph node metastasis. So I would, if I were to propose any sort of resection, which I would, if this is the only site of disease.
Okay, okay. So that's kind of what we did. I again mapped out the perineum, and I thought that this would be a reasonable candidate for surgery. Dr. Berber, would you consider chemotherapy prior to operation, or just given his year-long disease-free interval proceed to resection?
You know, he got the nitro protocol in the past. I think that given the interval, I would proceed with resection.
Okay. Yeah, and I thought about this a lot because, as Ellen has pointed out, you know, these patients don't do very well in general once they metastasize to the liver. So I was really cautious because I think if it was standard rectal cancer, I would have been very comfortable proceeding with resection. But I did go ahead and take him to resection, and I just wanted to show you what ultrasound looked like in this gentleman. So this is a case we did fairly recently, and this is actually our fellow doing the ultrasound. Shout out to Terrence Jackson. So here we are. We're looking at our hepatic veins. You've got right, middle, and left. And just to show again, relationship of tumor to that right hepatic vein that you saw on the MRI. So this is right hepatic vein, and you can see tumor involved. So based on outflow, I felt on preoperative planning that we needed to do a right hepatectomy on this patient. This is another set of imaging showing the lesion over here with relationship to the portal vein. And you can see this posterior lesion is fairly low density. It ended up actually being sort of a cavitary squamous cell carcinoma there too, but there's a more solid component over here. You see the right portal vein and anterior and posterior sectoral branches here, right there, anterior and posterior sectoral branches. So that was nice relationship to the portal vein. Also based on portal venous anatomy, I thought in order to get a margin, I could not do a posterior sectoral resection for both the outflow and the portal vein margin. So again, just to show you, now we're looking at left portal vein over here, and you can see relationship of tumor here in this corner to left portal vein. And then what I routinely do at the end of my cases is I do a Doppler, I use ultrasound with Doppler to document flow in both hepatic artery and portal vein. You can see our resected liver over here, and we're documenting flow in the left portal structures. And then here again, you can see portal venous flow over here that we've documented. So I thought this was a good example of how ultrasound really helps in these cases, especially to correlate with what we saw on the MRI. Dr. Ainetti, I know I'm preaching to the choir. I just cannot imagine doing liver surgery without ultrasound. One thing I'm always really taken with every time I watch you operate is that your continuous use of ultrasound. It's not just, you know, you ultrasound at the beginning and then stop. I mean, as you're coming through parenchyma, you just continue to go back, and I think that's a really important tool. Do you want to just comment on that, David?
Sure, absolutely. Again, ultrasound is absolutely critical when you're going through solid structures like the liver. And again, we use ultrasound routinely to map out the vascular structures so you have a sense of direction. And then, depending on your approach, if you're going to do a posterior approach, pedicle approach, anterior approach, whatever it is, but say you're going down anteriorly, you know, you go down a centimeter or two, and what you're doing is, and it's actually nice to score the capsule first, and then transversely, you put your ultrasound probe and come back along the liver, and you'll have an acoustic shadow from your Bovie score on the surface of the liver, and that'll project an acoustic shadow of your planned transection line. And from that, you can see where you have significant vascular structures. Then as you're going through the parenchyma with whatever devices that you're using, about every 1 to 2 centimeters, your repeat ultrasound so that you are identifying structures sort of, at a 1 to 2 millimeters away, and it really is just small angle adjustments that you're making as you're going through the parenchyma and working your way down to the cava and the hepatic veins.
And I think that tool of scoring parenchyma is so beautiful. I think the two big things I've really learned from you have been the tool of scoring parenchyma to see your line of transection, and the second thing is using color flow as you're ablating. That's just beautiful. It really, really helps. So in the interest of time, let me just do one other quick case. This is a 75-year-old female who was diagnosed in 2016 with rectal cancer, T3N0N0. She had she subsequently developed a lung lesion that was biopsied, and it was adenocarcinoma, and she was treated with stereotactic radiosurgery to that. She then received chemotherapy, but was very abbreviated because of her lack of tolerance of oxaliplatin. She actually had a very significant reaction and didn't want any more chemotherapy. So she had sort of minimal chemo with 5-FU-based regimen. And since 2016 July, she's basically had no further evidence of disease, including in her rectum, which was left in situ. She had a colonoscopy that was negative. And so just to kind of cut ahead, because we don't have a lot of time, she had ongoing surveillance. I think the question for us, because I do my own colon resections, is, what to do when you've got no evidence of disease in the face of known metastatic disease, and the primary is in situ with no evidence of disease. She had a PET in June of 2019 that showed uptake in the rectum that was very minimal, a liver lesion, and some mild uptake in the lung, in the previously stereotactically ablated area. This is the lung lesion. That looks, it's a combination of radiation, but also some uptake on PET. This is the liver. And I just wanted to show the relationship to the right hepatic vein there. And then relationship to posterior sectoral branch of portal vein. This is not tumor. This is the only lesion that we have at very close proximity to the portal vein. So, Dr. Cho, what would you do in this case?
I would get a biopsy of that liver lesion, prove that that's cancer.
Okay, it is metastatic rectal cancer.
Is the patient obstructed at all from a rectal lesion?
No, it's not found. So I actually got a colonoscopy. There was no evidence of disease in the rectum, and there was nothing seen on pelvic MRI either, just some thickening.
Well, okay. And I guess that I'm assuming that they did biopsy in that region that came back negative, right, sir?
Correct.
Okay, so we're looking at a pancreatic lesion in the liver and possibly the lung here, although that could be radiation-induced kind of PET avidity. So we're really looking at a liver lesion from the rectum. The question is, and the patient, and so my usual algorithm for these is I usually tend to do chemotherapy. So the reason why is I'd like for the cancer to prove its biology. If the patient progresses in chemo, then the resection would have been kind of futile in her anyway. The problem with her is that you said that she didn't tolerate her chemo very well. Is that correct?
That's correct. But that was the oxali that she had the issues with.
Right. And there we have other agents that we can use. I would offer chemo first.
Okay. Yeah, and that's kind of what we did. We gave her 4 cycles of FOLFIRI, which she tolerated beautifully, actually. We used bevacizumab for the first 4 cycles. Colonoscopy was negative, and this is what her tumor did. So it actually decreased in size, but we're still in a tough location. So, Ellen Hagopian, what would you do now?
So the colonoscopy was negative, but what about her? Did she have rectal biopsies done? You had some PET uptake.
Yeah, no, they did everything, and
no, you had some PET uptake in the region of the tumor in the rectum.
It was very, very mild, but let's put that aside because we can take it out.
Yes, we can take it out. There are many things that can be done in this particular case. She could get radioembolization. She could get surgery. There's all kinds of things that can be done with this case, and we could talk for an hour about it. But
what would you do? We've got 1 minute. What would you do?
I think that, how old is she? How old is she again?
She's 72, but very active.
Oh, you know, I mean, I think I'd see what the patient wants first off, but I would offer her surgery, but I would offer her the options. You know, she has what's going for her. She's had a long disease-free interval, but I want to make the point to the residents and fellows is that this was going to eventually happen, right? You've got a patient with rectal cancer who presents with a lung lesion and nothing in her liver. She's eventually going to have this. She's eventually going to develop liver metastasis.
Great.
So what did you do?
Yeah. So we actually took her to the operating room. I had a long discussion with her, with the oncologist, presented her a tumor board. The idea was that we would do a right hepatectomy on her. I felt that the location was a bit large for ablation, although I know David would have probably done that. It was a bit central for me personally, and I thought about IRE in this case because of its location. We weighed all of those options. I offered her all of the above, including I think we need to talk about stereotactic surgery too. This is what we found, so I just wanted to show you what gallstones look like under ultrasound. So she lost her gallbladder too, obviously. And I thought this was a pretty picture. Again, left and right portal veins over here. And you can see our tumor sitting right here posterior to the right portal vein.
Mm-hmm.
And again, in this, you can see the hepatic vein coming in there, the right, middle, and left. And so right, middle, left. And tumor is just inferior to the entrance of the right portal vein. And again, just to show you relationships, so this is sort of cava further down, and you can see tumor lying right on cava over here. So I did a right hepatectomy on her. It was a tough resection because, again, this was really more sort of caudate than and right. And anyway, she did well so far. But I think there's a lot of, algorithms for this case, as Dr. Hagopian brought up. I do want to finish on time. We're 2 minutes over, and I have to go do a case now, actually. So I just want to thank all of our speakers for being on, and thank you, residents and fellows, for joining us, and Steve Lamb for staying late. I really appreciate it. And this has been really educational for me. I've learned a lot.